So, on examination, when we start to think about prolonged pregnancy or postpartum pregnancy, we shall have some evident signs which may tell us that this mother is probably having a postpartum pregnancy or a prolonged pregnancy. And this may be some of the signs and symptoms. The first one is, when we examine the mother, we are having increased uterine size due to continued fetal growth. Remember, at around 38 weeks, the pregnancy we shall have what we call what is it? Quickening, sinking, lightening. We shall have what we call lightening, and the pelvic girdle will give way and the head will engage. But as we examine this mother at 40 weeks, 41 weeks, there is no sign of lightening. So this can give us a clue whether this mother is having prolonged pregnancy. Then oligohydramnios, which is due to placental aging and reduced fetal urine production. This can be one of the signs of prolonged pregnancy. Then we have decreased fetal movement reported by the mother, especially just because of the decreasing placental insufficiency. And when you do a vaginal examination, the cervix will remain unfavorable, firm closed, and still posterior. So we shall look at the assessment of the cervix to assess whether this cervix is favorable for labor. We shall look at it. It is called the Bishop's score. So this examination can be found on the mother. And now when we talk about the fetus, we shall have two assessments. We shall have one intrauterine, and when the baby is born, that is retrospective. So on examination, we have a fetus who is bigger than 4 kilograms, that is 4 kilograms to 4.5. This is very prone to a prolonged pregnancy when we rule out cases of diabetes mellitus, and these may increase the risk of shoulder dystocia. So retrospectively, after, for example, the mother has delivered, when we look at this baby, the baby will have what we call post-maturity syndromes, or the baby may be called dysmaturity, and all these may be signs which may be seen in the baby after the baby is born. And when you look at this baby after being born, the baby will have a cracked, dry, peeling off skin. The skin will look dry, will look dehydrated and cracked. When you look at the baby's nails, they will be long, like they need even to be cut off, especially when this baby is just newly born. And meconium staining of the skin, nails, and amniotic fluid. When you deliver this baby, the amniotic fluid may look stained with meconium. The baby may look greenish with meconium staining all over the skin, and even this greenish staining can be seen in the baby's nail. So the babies will also have reduced subcutaneous fat. Why? Because due to placental insufficiency which was setting in. It means this baby was not feeding very well. And this baby will have increased alertness, or they will look like an old man. So, fetal heart rate or fetal distress may occur due to placental insufficiency. Like we said, that the placenta has grown to maximum and now its activities are coming down. So when we see this mother and confirm that this mother is having a prolonged pregnancy, what should we do? We are going to look at the management. And under management, we shall have different kinds of management depending on our assessment. But the first thing we shall do is what we call expectant management or close monitoring. It means we are not going to rush maybe to take this mother to theater or carry out an induction, but we are going to first closely monitor. And this will occur when the pregnancy is 40 weeks, 41 plus 6 days. What does it mean? We have not reached 42 weeks because we have said plus 6. If we clock 7, that it means we are at 42 weeks. So the expectant management, we are going to do it between 40 weeks to 41 plus 6 days. And we are going to do this if the mother and if the fetus are very stable. The maternal condition is okay, there is no problem with the mother, and when we assess the fetal condition, it is also good. So we are going to do what we call fetal surveillance or fetal monitoring. And the first method we shall use is a non-stress test. Here, this is very common to most of us. We shall use a fetoscope, a stethoscope, to assess the fetal heart rate, the variability, and the reactivity. Fetal heart rate, is it okay? How is it variable? Is it stable? Is it normal, in the actual normal range? Is it strong? All these things we shall listen to this. And when we are okay with them, then we shall continue to monitor the mother. Then we shall also do what we call the biophysical profile. Most of you see these results on the scan. And this biophysical profile evaluates fetal well-being using ultrasound scan. And when they look at this, basically they look at the amniotic fluid volume. Is it sufficient enough? They look at fetal movement. Is the baby moving very well? How is the muscle tone? How is the breathing? And also we continue with the non-stress test as explained above. So this is examined through ultrasound scan. Then we have a Doppler ultrasound of the umbilical artery. This is used if fetal compromise is suspected. What we mean by fetal compromise is when we think that the fetus is not well, the fetal heart is not so good, we shall do a test called a Doppler ultrasound of the umbilical artery and then see whether their baby is safe. Then we do what we call a daily fetal movement count. In most cases, they call this fetal kicks. We teach the mother to monitor the fetal kicks and report any decrease. By fetal kicks is we give a paper and pen to this pregnant mother, and this pregnant mother usually sometimes is admitted on the ward, a quiet ward, not in labor ward, and we tell this mother to tick every fetal kick they feel like we tell them that in 30 minutes, whenever the baby kicks, you tally. And we see like in 30 minutes, how many fetal kicks did we get? In the next 30 minutes, how many fetal kicks? In the next 30 minutes, like that. So this mother can be okay, maybe in the first 2-3 days, but as the day or period goes on, for example, if we had 10 fetal kicks in 30 minutes, we can start deteriorating and having 8, having 6. Then this means there is a problem with the baby, and that is we can switch to another management. But all these methods are under fetal surveillance. Fetal surveillance is meaning closely monitoring both maternal and both fetal condition, and see when they are good, we are looking at the expectant management. We shall wait till maybe labor starts by itself. So note, if we get any fetal distress, if we see any oligohydramnios, placenta insufficient, we switch to induction of labor or cesarean section may be recommended. What does it mean? That as we are managing our mother, we are using the expectant management or the close monitoring management, and basically we are doing fetal surveillance method, looking at the well-being of the fetus. But if we find that when we are doing all this, fetal distress sets in, oligohydramnios sets in, when we use the ultrasound scan, we have placental insufficiency, then we automatically switch to another method, either induction of labor or cesarean section.